Hi everyone. If you are new to this channel, I am Dr. Himadri. So let's talk about aplastic anemia today. So what is aplastic anemia? You can see this is a bone marrow uh, biopsy sample. So let's begin with aplastic anemia. The definition of aplastic anemia. Aplastic anemia means there is hypocellular bone marrow without any fibrosis or without any dysplasia. This is called as aplastic anemia. And as there is hypocellular bone marrow, that is the cellularity of the bone marrow drastically reduces, there is usually pancytopenia outside within the blood. It may not start with pancytopenia. Usually it starts with a lineage issue, that is bicytopenia, and eventually it involves the pancytopenia. Initially there is a reduced amount of RBC, that is anemia, as well as thrombocytopenia, but later on the neutrophil line, that is the WBC line, actually affects. So what are the causes of aplastic anemia? We can broadly divide aplastic anemia into two categories. One is our congenital bone marrow failure syndrome. This is important because in infant, that is less than 1 year of age, the most common causes for aplastic anemia usually we look for the congenital bone marrow failure syndrome. The most common causes are Fanconi anemia. There could be DKC, that is dyskeratosis congenita, or it could be SDS. SDS is your Schwarzman-Diamond syndrome. Okay. So aplastic anemia, the another group is acquired aplastic anemia or immune mediated aplastic anemia. Earlier we were not able to find out the actual cause. Right now by giving immunosuppressive therapy, we are getting good results in this patient. Therefore we are using these things as a treatment modality. So that's why we are calling acquired aplastic anemia as immune mediated aplastic anemia. Okay, the actual causes for aplastic anemia is still unknown, but in some patients what we actually found that in chromosome number 6 there is loss of heterozygosity in chromosome number 6, and which is responsible for few things as in this patient. One is there is reduced amount of T regulatory cells, that is CD4 positive T regulatory cells are reduced, and on the other hand there is oligoclonal CD8 positive T cells are increased. Look here, these are your naughty CD8 positive T cells. What they are going to do, they are actually, they are cytotoxic. They basically kills your own cell where there is intracellular organism or viruses like that. Okay, so what is actually happening here, your CD8 positive T cells are killing your own cells, which are very important, that is hematopoietic stem cells. This is your bone marrow hematopoietic stem cells, and your oligoclonal CD8 positive T cells are going and hitting and also killing these hematopoietic stem cells. Therefore there is pancytopenia outside. So this is actually what is happening, but in maximum patients there are some trigger. These things is all this T cell mediated damage doesn't starts on its own. One thing is that there should be some genetic predisposition, and on the other hand there should be some trigger. When both those things are actually together, there is aplastic anemia. So what are the triggers? Triggers are actually hepatitis B or hepatitis C. You have seronegative hepatitis, or you can have CMV infection or EBV infection, parvoviral infection, or mycobacterial infection. There are some drugs which are notorious to cause aplastic anemia, like high doses of NSAIDs, non-steroidal anti-inflammatory drugs, or could be sulfonamides, golds, and chloramphenicol. And systemic disease, never forget SLE, and also PNH, that is paroxysmal nocturnal hemoglobinuria. So from this what you can understand, the immunosuppressive therapy, if we start immunosuppressive therapy, it is going to be the treatment in this patient, because there is immune dysregulation or immune dysfunction, and your own CD8 positive cells are upregulated, whereas T cells, which are regulatory cells, are downregulated, and the CD8 positive cells are killing your own hematopoietic stem cells, and also therefore the hematopoietic stem cells are reduced in number, and there is pancytopenia. So how we can actually classify the severity of aplastic anemia? It is classified as severe aplastic anemia and very severe aplastic anemia. The severe aplastic anemia is when your bone marrow is less than 25% bone marrow cellularity. Cellularity is reduced less than 25%, and your correct reticulocyte count is less than 1%, and ANC, that is absolute neutrophil count, is less than 500, and platelet count is less than 20,000. We call it severe aplastic anemia, and very severe is when your absolute neutrophil count is less than 200. Okay, so remember this thing: less than 500, less than 20k, and your retic count less than 1%, less than 25% bone marrow cellularity. Severe aplastic anemia less than 200. Okay. Now, what we were actually discussing earlier, that this is the bone marrow, what you can see from here. In the bone marrow, these are actually your fat cells, these rounded cells, all these rounded cells are actually fat cell, and these cells, you can see the dot cells, these are your normal hematopoietic stem cells or blood cells. So most of the things is most of the marrow has been infiltrated by your fat cells, but there is no fibrosis, no dysplasia. Remember this. Okay. So what is the clinical approach? How do you actually approach this patient and treat this patient? This is aplastic anemia. Most of the cases when diagnosed less than 1 year of age, that is inherited bone marrow failure syndrome. Most common is Fanconi anemia, DKC, dyskeratosis congenital, and STS. And you know, in Fanconi or DKC or STS, we have another treatment modality that is called as androgen. We actually use androgen, anabolic androgen in this patient. It actually acts via the estradiol receptor, and the main problem in these cases, mainly in the DKC and STS, is that there is telomere shortening. What happens after each cycle of cell division? Usually there is telomere shortening, and there is another enzyme which is basically adding the telomere. Therefore, the cell potential or cell can differentiate for more time. So this enzyme is actually termed as telomerase enzyme. So this telomerase enzyme actually being stimulated by via the androgen, via this estradiol receptor. So androgen is used in FA, DKC or STS. Okay, but the ultimate treatment is hematopoietic stem cell transplantation from HLA matched sibling. So we have immune mediated, that is immune aplastic anemia. Main treatment for hematopoietic stem cell transplantations, we know this. Therefore, we must try to look for the HLA matched sibling is present or not. Look, if HLA matched sibling is present, so we go for hematopoietic stem cell transplantation from MST. MST means HLA matched sibling donor. If the donor is not available, what we actually can do is ATG, that is anti-thymocyte globulin. Horse anti-thymocyte globulin is used. The dose is 40 mg per kg per day, which is used for 4 days. Here what we are doing, we are firing our thymus, because you know the thymus is responsible for this immune dysregulation, that is CD8 positive cells. So we are attacking the thymus, T cells are reduced, they will not further fire the hematopoietic stem cells. That is the idea. And also we add cyclosporine and steroid methylprednisolone, and these are actually immunosuppressive therapy. We look for the response in next 1.5 months. If the patient is responding well, we continue the cyclosporine for another 1 year, rather 1.5 year, and we consider the dose over next 6 months. Okay, let's say the patient is not responding well. What we can actually do? We can actually look for the bone marrow hematopoietic stem cell transplantation from matched unrelated donor. MUD means matched unrelated donor. If there is 10 by 10 HLA matching, we can actually go for this. Suppose it is not available, the second option in our bucket is once again ATG and steroid, that is anti-thymocyte globulin and steroid, or we can go for cyclophosphamide, or even we can go for alemtuzumab. Okay, so look here, another photo. This is your normal bone marrow, and this is your aplastic anemia bone marrow. What is happening here? There is too much of fat cells which are infiltrating, and normal cell population, that is normal hematopoietic stem cell population, is reduced, but there is no fibrosis, no dysplasia. Another photo, that is how the bone marrow aspiration is done from iliac crest. You can see this is the spongy bone, this is the marrow. From the marrow it is taken out. Okay, so thank you. If you find it helpful, please consider subscribing for more such videos.